Thank you very much. We would like to open the scientific part of the conference with the first session, Molecular Basis of Disease. My name is Matthis Synofzik from the University of Tübingen, and I have the pleasure to join together with my colleague, Mr. Napiala, to chair the first session. And I was always also invited by the organizers to give the first talk, and I'm very grateful for this. And this first talk I'm going to present, it just has to go up. So the first talk I'm going to present is about next generation sequencing. And when I was asked to give this talk, I was wondering whether I should focus more on new genes, but I decided not to do this because you will see new genes in the later talks. Thank you. And we'll see new genes in the later talks and also on the posters outside. But I rather wanted to focus on more conceptual points, conceptual insights, challenges and next steps, and illustrate them by empirical examples from recent studies which we or others have been doing. So don't expect new genes, but more conceptual points which I would also like to discuss, maybe also during the later talks and during the next days. And let me start with insights. What kind of insights have we gotten in the last years? One of the main fields in ataxia genetics where we have received new insights is the field of early onset and recessive ataxias. For example, we have done a study where we subsequently screened a series of 182 patients with early onset ataxia compatible with recessive ataxia, so either multiplex or recessive or sporadic, and where Friedreich was excluded. And what if we do an NGS sequencing on this consecutive series, what do we find there? First of all, what you see is we were able to solve 554 patients out of those 182. And what you see just by having a first glimpse at it is seeing that those genes, each gene accounts for a relative small number, small fraction of overall cases. And this shows you for clinical practice that NGS it should be the first line diagnostic tool. Single gene diagnostics is hardly of any value anymore for a genetic workup of an ataxia patient, unless you have a clear-cut imaging or fluid biomarker. But if not, you have to go for NGS. But this is pretty trivial. What is more new? What is more interesting from the numbers? If you have a closer look at the numbers, what you see is what are the most frequent recessive ataxias in this consecutive series? And what you see that the most frequent are IRAC, SPG7, and SIN1. And for example, what are not the most frequent recessive ataxias? For example, not ATM, not ataxia telangiectasia or others. So maybe those three recessive ataxias were not the first ones which came up to your mind. So I think those results are a little bit surprising, but the Paris group from Giovanni Servonin has a very, very similar results. So I think we have to reframe our frequency estimates of the frequency of the respective recessive ataxias. But why is it important to find this out, the relative frequencies of the recessive ataxias? I think those indicate hotspots where to look for to form new trial-ready cohorts. And I think IRAC, SPG7, SIN1 are good hotspots to form trial-ready cohort. And in the PREPARE consortium, we're already starting to form a trial-ready cohort for IRAC, and SPG7 might be the next one. And also SIN1 would be a good candidate to look for natural history studies to perform biomarker studies. So I think those will be interesting recessive ataxias frequency-wise to focus on in the next years. But why are those, especially those three ataxias, interesting as well? Those three ataxias exemplify that the boundaries from ataxias to other neurodegenerative diseases are fluid and variable. And I would propose that we should start thinking outside of the clinical boxes, because all three of those recessive ataxias do have a spasticity component. In SIN1 more variable, in SAX1 almost every SAX1 patient has spasticity, and SPG7 also 7 more variable, but all of them have more or less a spasticity component to them. And you can tell this by SPG7, it also comes from the HSP nomenclature. So what I would think is we have to think outside our classical boxes of clinical thinking, and the classical nomenclature of phrasing dominant scars in the SCAR nomenclature or recessive scars in ARCA or SCAR nomenclature versus, for example, HSP classifications. Those nomenclature have been interesting, but I don't think this will lead us anywhere. If you have a look at the field, you can discuss longer. Is this now SPG 98 or is this ARCA 12 or 13? I don't think this will lead us anywhere. We have to step beyond those clinical classifications. And just to pinpoint this, because for ataxia specificity, this might, you say, okay, by this point. But I want to make this point larger because I think the ataxia overlap is not only with the HSPs, but it's also for epilepsy, and the boundaries dissolve there. And I have one example from one of many examples where the boundaries between ataxia and epilepsy dissolve. And this example is a gene called KCN2, and you see a patient with a de novo mutation. And this gene has been established as an epilepsy gene. But if you have a look at some of the patients, for example, this patient, if you could click on second number 13 on the video, second number 13, you will see an ataxia phenotype. Right, so you see that broad-based ataxia gait, and he has cerebellar dysarthria and cerebellar upper limb disturbances. And he has cerebellar atrophy on the MRI. So this shows you that this was just one example of a gene which comes from the epilepsy field, which does also lead to an early onset ataxia clinically and on imaging. And there are many examples of this, and we have now learned for this gene that it does not only cause epilepsy and ataxia, but also HSP. There's no series out there. So the boundaries between those disease concepts are dissolving. And there are more, if you can stop the video, thank you. There are more channelopathies which cause this disease spectrum between epilepsy, HSP, and ataxia. And why is this interesting? I think it's interesting because it tells us to go beyond the classic phenotypes. For example, in this patient, we have found a gain of function mutation in KCNA2. This gain of function mutation is interesting because there is a drug existing already on the market, and this drug is called phenylaminoprotein. Especially in the ataxia world, you know this drug quite well because we have been trying it in different ataxia patients. But what is interesting is that this drug quite specifically targets this channel, this potassium channel, and reduces the hyperactivity, so it works against the gain of function mutation. So this is a quite individualized molecular targeted treatment specifically for gain of function mutations in this gene. So here we have used NGS not for gene hunting, but to find an individualized molecular targeted treatment. And I think this is a new way also of thinking about NGS, not just for gene hunting, but to reclassify diseases and to go for molecular treatments. And I want to sketch out this with a graph, what the conceptual point behind this. So we have been used in the ataxia field to classify attacks like ARCA, SCARS, or with the movement disorders classification is now proposing ATX prefix, or we have been used to use SPG7 or HSP classifications or HSP prefix in the movement disorders classification. I think those are helpful from a clinical point of view, but I think in terms of diseases, and if we really now want to get to translation for ataxias, we have to go beyond those disease phenotype-based classifications to molecular classifications, classifying diseases either by genes or by pathways, depending on the type of diseases you look at. And this does allow us to find target treatments. For example, if there's HSP with phospholipid disorders, so we have quite a number of HSP genes caused by phospholipid deficits. There might be a common set of genes leading to those pathway deficits, which might be treatable by same or similar substances. Or if you have a certain repeat disorder, and we'll hear this later on, you might find a way to target those repeat expansions and have a common treatment depending on the genetic mechanism. So my proposal is to move beyond the clinical classifications to molecular classifications. Why? Because I think this will be the goal to treatments. And this is one of the purposes for NGS, to go beyond gene hunting, to be the bridgehead for molecular treatments. So this was one of the insights, or several of the insights we were having in the last years. But in the last years, we were also confronting several challenges, and one of the challenges is the high amount of missense variant and dominant SCAR genes, and dominant ataxia genes in the SCAR genes. This has been pointed out by Stefan Puls at this ARC conference already a few years ago, but this problem is now reaching clinical practice. And let me illustrate this problem. I've shown you the recessive genes, but on the right hand in our series, you also find dominant genes. And some of them, for example, SPTBN2, SCAR5 gene, CAGNA1, or ITPR1, are quite common missense variants in those genes, and you find them quite frequently. And the problem we are facing in research as well as clinics is which ones of those variants are really pathogenic, and how can we show that they are pathogenic? And you will see those slides in many presentations and many publications on early onset ataxias. And I really would like you to be cautious on believing those numbers unless there's a functional proof. And you see this not only for those genes, but also the gene for SCAR28, AFG3L2, or TGM6. There are many missense variants, and we found them in many patients, but you have to be really careful whether they are pathogenic or not. And the problem this now faces comes to clinical practice. I have patients coming with me with this genetic diagnosis, or it's a SCAR35 diagnosis, and they're having a vasculitis or something. That's just because exams are being done, and patients do receive those reports about those missense variants, and this are reported back to the patients, and they come to the office and they believe they have this type of scar. So this is a problem which is reaching the clinical practice. And just to illustrate this, I want to illustrate this by the example of ITPR1, which is causing SCAR29. We have done a screening study in early onset ataxia, and we have specifically focused on de novo mutations in early onset ataxia. We have started with a discovery cohort of 121 ataxia patients with early onset ataxia. We found that 3, so equaling 2.5% of those patients in this series did have SCAR29 caused by de novo mutation in ITPR1. This is quite recurrent, and then we had a validation cohort from the US, mainly US, so from North America, and then we found about the same and even a little bit higher numbers. So this shows that ITPR1 is really a recurrent gene causing early onset ataxia. But what is the problem with the gene? So I think those findings are quite robust in terms of the de novo mutations. But in the second step, we had to look, okay, if we find those ITPR1 missense mutations, how many of those are inherited? And what we did find that 8 of the 11 mutations we found were inherited from healthy parents. And the parents were really examined by us, who were really healthy. There was not even a little bit mild phenotype, there was no phenotype at all. And this led us to question the inherited variants, are they pathogenic? And we believe at least not all of them are probably not pathogenic. And we had a closer look at those 8 variants. And in 3 out of those 8 subjects where we found those inherited ITPR1 variants, we found that other ataxia genes, and with those ataxia genes we were fully explaining the phenotype, so there was nothing left to be explained by this ITPR1 missense variant. It was fully and completely explained. So again, adding to our skepticism whether a good share of ITPR1 missense mutations is pathogenic. We went then on and see in the general databases which are out there, how often do you find ITPR1 missense mutations, even if you look only for the ultra rare ones and the very well conserved ones, to really put the levels high. How frequently do you find just ITPR1 mutations in general health and across diseases? So we looked at the databases, and we found, for example, in XX49 databases or in Genesis, which has Alzheimer's, cardiomyopathy, and so on phenotypes, and you find those ITPR1 missense across diseases, and I do not believe that ITPR1 causes all those kind of diseases. So I rather think that those missense variants, most of them are unspecific, and I really think that most of the ITPR1 missense mutations which are out there have no or only minimal effect on the clinical phenotype. So how can we deal with this in clinical practice and in research practice? One of the things we then usually do, we have a look at the in silico predictions. So we were checking whether the ITPR1 de novo mutations, which we are quite sure that they're pathogenic, do differ from those inherited mutations, or those mutations which you find in the general databases. And what you said, we were testing different kind of in silico tools, and you are familiar with this if you're doing genetics or whole exome sequencing. And what you find is, yes, those mutations which we believe are pathogenic or have functional evidence, they do cluster in the lower or upper range of the respective in silico score. But in gray, you see those variants which you find in the general databases or which are inherited. And you see that they also cluster at the upper limits. So there is no clear-cut distinction, even if you combine those in silico prediction tools by which you can predict whether the predicted pathogenic mutation is indeed pathogenic or not. So this really puts high caveats to the in silico predictions if applying this to the missense scar variants, and this is a problem for the field. And I don't find another solution unless doing functional studies. So what we have done, we have taken a set of those ITPR1 mutations and tested them functionally, and for all of the de novo mutations, we were able to show a loss of function of IP3-induced calcium release, so saying there is a pathological dysfunction, whereas, for example, one of the inherited ones, this behaves like wild type, there's no dysfunction. So I think the standards are going high in molecular genetics, that especially for the missense variant in scar genes, I think we can only be sure if you have functional evidence. Because even small pedigrams, if it co-segregates with disease in small families, this will hardly help you, because this co-segregation can just be by chance. So this is one of the challenges we are facing the missense variant in conventional scar genes. What are the next steps to do? One of the next steps to do is to target the missing heritability which we face in ataxias. I've shown you, for coming back to the series, which I've shown you earlier, is we have solved 55 of the patients, equaling 30%. But this means, vice versa, 70% of the patients are still unsolved, and we have no exome data, and they're still unsolved. And this is an interesting and astonishingly uniform finding across different labs worldwide, that there's still, depending on the cohort, but it's always between 60 to 95% of the patients remain unsolved even after whole exome sequencing. So about 70 to 80% remain unsolved even after NGS sequencing. So there is still a lot to do in the genetics field to target this missing heritability. And I think this will be the genetic task for us to do in the upcoming years. And I do not, of course, have the optimal solution to this. But if you look at what we have been finding in the last 2 to 3 years, there are already some glimpses on which direction we might go to decrease this number of patients which we are still unable to solve. And what might be some of the approaches to reduce this number of still unsolved patients? One of the approaches is look more systematically for de novo mutations. I've shown you that in early onset ataxia, ITPR1 is quite frequent. I've given you this case example from KCNA2. And I think there's still much more out there with respect to de novo mutations. And if you come from the epilepsy genetics field, this is totally boring. Of course, you have to do trio whole exome sequencing. But I'm not yet aware of a larger cohort, consecutive cohort, who has done in about 50 to 100 patients, ataxia patients, who has been doing systematically trio whole exome sequencing. I think this will be one of the jobs we should do. And to tell our patients and families that we need the parents in order to solve the patients. And because de novo mutations will be there, and they will be there not only in the congenital ataxias, they will be there across different age groups. A second step to go is to look for the non-coding space. And there's already some preliminary evidence from some genes that it's worthwhile to look at the non-coding space. We have found a deep intronic mutation OPA1. If this is located in trans with the second OPA1 mutation, it gives rise to very severe optic atrophy plus syndromes. Bear syndrome it's also called. But we found this also by looking at deep intronic mutations. And I guess there will be more deep intronic mutations which we are missing so far. But now the genomes is one of the steps to go to find those deep intronic mutations. But you don't only have to look deep intronic, but also near intronic, more closer to the exonic space. And the good examples came out quite recently. Leaky splice site mutations in the gene called PODR3A, which has been called to, which leads to spastic ataxia. And it's actually quite recurrent cause, and especially those mutations, those near, those leaky splice site mutations are quite recurrent cause of spastic ataxia. So this are examples which show that the intronic space is good to look at. We just need to come up with the tools to sort out which ones are pathogenic or not. But this is another next step to take. A third next step to take is I think we should join forces worldwide and collate our NGS data sets, our whole exome and our whole genome sequences. And if you look at Alzheimer's and ALS, you see all those large consortia. But we should be able in the ataxia world to do the same. Why can only ataxia and Parkinson's and ALS world do this? In ataxia, we can do the same and collate our exomes if we're ready to do this. And I think there are already infrastructure out there to do this. For example, the Miami-based pipeline called Genesis. This pipeline already has 350 NGS data sets from ataxia patients. So there is already something to build upon. And if we join forces and join our NGS data sets of unsolved ataxia patients, this will help us to increase the numbers. And if we have them in one database, for example, we find it will be much more efficient in finding second families for matchmaking. Also, we will be able to do mutational burden analysis. So far in ataxia genetics, hardly anybody has trusted to do a mutational burden analysis. Why was that? Just because our sample sizes have been too small to do mutational burden analysis. But once we join forces and build an ataxia exome consortium, we will have sufficient numbers to do a mutational burden analysis. So this will become a tool in ataxia genetics as well, as we have learned from Parkinson's, ALS, and so on. And that is possible, at least in principle. We have shown this, for example, by the example of NPC1 and by the example of ITPR1, that you can do, even with smaller numbers, about 200 to 300 NGS data sets, you can do mutational burden analysis and do have some positive findings there. But those are, I think, just proof of principle studies. I think that there's still some more way to go for us. So I think those are different approaches to cover the missing heritability, to reduce the 70% of unsolved ataxia cases. But what can we do with all those solved cases, which have been solved by all of you at your local centers by NGS? What should we do with them? And I've shown you that all of those genes just account for small fractions of ataxia patients. And they're all sitting at each of our centers. And again, I think we should also on this level join forces and bring together our scattered fractions and bring together with those scattered fractions of patients and join forces in terms of clinics and basic science in order to get ready for trial and bring them to trial. And which building blocks, which translational building blocks are needed in order to really translate the NGS success, which we all have been seeing the last 4 years, bringing this to clinical trial. What do we need? We need different elements. One of the elements is we should collate our patients in registries. I cannot work with 5 IRAC patients. I can never do a study with 5 ITPR1 patients. But if we have 20, 30, 40, 50 altogether, we can do the natural history studies. With natural history studies, that's one of the columns for future treatment studies. And we can do biobanking collectively and find fluid biomarkers. But we have collected them in a registry. And for example, Thomas Klockerter from Bonn is leading a SCAR registry, which is also including the SCARs, not only the repeat SCARs, but also the one with conventional mutations, SCAR mutations. And there's hardly any I'm not aware of any natural history study for the SCARs with conventional mutations. But those registries are one tool to do those natural history studies. And we are from the PREPARE consortium, we're having a recessive ataxia registries where we're collecting recessive ataxias. And if we collate forces and join forces, we can do the natural history studies and biomarkers. And there's another problem. We have hardly a standardized way to collect biomarkers so far. But I think we should start to, on a routine basis, sample our patients for fluids, at least for fluids, and to be ready to find biomarkers. And this should be just a routine workup. Like a clinical examination, we should enter our patient into a registry and we should sample biofluids for future biomarker studies. And those clinical efforts have to be complemented by efforts on the basic science side. And you would see different talks today, this afternoon, and tomorrow on the basic science side, talking about different causal mechanisms, some model systems, a little bit less on compound testing. But if both clinics and basic science do their homework, and then we are ready to go. And we should not do this in series. We should not wait until there is a good compound substance from basic science and then do our clinical homework. We have to do this in parallel. We have to get ready. So once there's a good compound showing up from basic science, we have to be ready also in clinical terms and have our cohorts ready. And I think this is the task we have to do to translate the NGS efforts and not just stick and find another gene, gene 110, gene 111. I think the next step is to translate this and really come back to the patient and do clinical trials. But this is also financially or politically an important point. Hardly anybody is willing to fund registries. This is not very sexy to do, to fund registries or to fund biobanking. This is, wow, this is just an infrastructure. But I think this is what is needed. And this is also a question to UK Tax and so on, whether we can do some funding for structural resources, which are the structural resources for future clinical trial. Because it's hard to get funding for those structural resources, but they are necessary if you do or want to do your homework. So to conclude, what were the insights? I think in terms of the recessive, the non-Friedreichia recessive ataxias, sign 1, IRACs and SPG7, but not, for example, ataxia telangiectasia are the most frequent non-Friedreichia ataxias. Why is this important? I think those 3 might be interesting cohorts to do natural history studies, find biomarkers, and bring them to trial. And again, we have already started with IRACs and we're now moving on to SPG7. The next thing, I'm proposing that we move beyond the clinical classification systems for ataxias. They do have some value for clinics, but if you want to go for treatments, we have to come up with molecular defined classification systems which go beyond this classical numbering with the classical disease classifications. And if we find common pathways and classifications, disease-based classifications, this will be the door to therapy. Just with the insights, what are the challenges? One of the main challenges is a high number of missense variants in conventional scar genes. And they was a research. I have so many papers to review about new phenotypes, about ITP1 genes or in CAGNA1, and I just don't believe this because there's no functional evidence. And this is posing a problem to the research field and to clinical practice. And the problem is that even if the gene variants are ultra-rare and predicted to be pathogenic, you'd still find them, as I've shown you for ITP1, you still find them across health and disease. So those in silico tools do not help you to finally decide. And probably you need functional confirmation. If you do not have a functional confirmation, just be very, very careful. And especially if reviewing papers about new phenotypes, be very careful in accepting those. What are the next steps? One of the problems we're having is still this high share across labs of about 70 to 80% of patients which we still cannot solve even by whole exome. How can we tackle those? Well, different ways. One is to focus more systematically on de novo variants and on the intonic space, and there are promising variants, promising genes out there that this is a good way to go. And I think we should come together and join forces for NGS datasets. Think about the vision of having an ataxia exome consortium like ALS, like in PD world. We can do this. And we have to translate the success from gene hunting. We have a responsibility there and go from the genes which we have found to treatments. And the way to do this is form tri-ready cohort, and the necessity for this is to have collaborative registries and biobanking. And they are already out there for the dominant as well as for the recessive ataxias. And I think this might be just minor steps to start to get to treatments. And maybe we will be successful at the end. But as long as we do not have drug treatments yet, we might also be successful. For example, this patient is one of my ITP1 de novo patients. And despite her disease, she has been participating in a run and has received a reward for participating in this run. So we have positive messages for our patients, even though they're still waiting for drugs out there. But there are also other ways to be happy. Okay, thank you, everyone.